शेयर करो इसको। हाँ आपकी देखो कोर्स नहीं रखी कोई नहीं रखी आप है। शेयर किया हुआ है बस कुछ। जी गुड मॉर्निंग एवरीवन। I am presenting a seminar on topic pathophysiology of urinary tract obstruction. Its prevalence is 10% and most commonly seen in women between the ages of 20 to 60 years, in males after 60 years, in children mostly less than 1 year. Flank pain is the most common symptom, which can radiate to lower abdomen, testicles, or labia, associated with nausea, vomiting. Chronic obstruction is usually painless. Bladder obstruction may have voiding symptoms. Anuria is rare, and it should be considered in patients with new onset hypertension and renal failure. And it should be suspected in recurrent urinary tract infection. Progressive deterioration in unilateral asymptomatic obstruction ranges from 20 to 40%. Damaged kidney does not have the functional reserve of normal kidney. Children may show adequate renal function in early life, but may progress into renal failure in adolescence. Here we can see the fractional excretion of sodium, according to which we can suggest the renal cause, or post-renal cause. If fractional excretion of sodium is less than 1%, it is prerenal, more than 1%, it is renal, and more than 4%, it indicates post-renal cause. Normal GFR varies generally with decreases with the age. Creatine remains the imprecise because it is variable with the age, gender, race, and muscle mass. Chronic kidney disease epidemiological correlation equation and Schwartz equation are used for GFR calculation. Now, cystatin is more accurate marker of GFR, and it is not influenced by the muscle mass. Renal ultrasound remains the first line of imaging as it does not require the iodinated contrast, and it does not cause ionizing radiation toxicity. It can be safely performed in patients with renal insufficiency or contrast allergy. Ultrasound is normal in 50% of patients with urinary tract obstruction, and it can calculate the resistive index. And zero point 0.7 is considered the upper limit of the normal in adult. It can exceed in children at least 4 years of age and in elderly patients. Its sensitivity is 92% and specificity is 88%. Difference of zero point 0.1 diagnosis can be made. Color Doppler are also used to identify the urethral jet in the bladder, and ultrasound may detect calculi as small as 0.5 mm. Ultrasound has sensitivity of 45% and 94% specificity in detecting urethral stones, and 45% sensitivity and 88% specificity in detecting renal calculi. Ultrasound overestimate renal stone size as compared with the CT. 99 technetium Mag3 is preferred for diabetic renography, and which is actively secreted by the tubules. And DTPA is also used, which is exclusively for GFR calculation, which is removed by the glomerular filtration. It is limited in the patient with renal insufficiency and patient with less than 6 months of age because of immaturity of kidneys. Non-contrast CT is the imaging of choice, and it can even shows the signs of urethral obstruction even after the passage of stone. It has sensitivity of 96%, and excretory phase is also performed to evaluate the urothelium. Magnetic resonance urography is also used for anatomical and functional information. It can show the renal transit time, and normal is 4 minutes, equivocal is 4 to 8 minutes, and obstructive if it is more than 8 minutes. The risk in MRI is the development of nephrogenic systemic fibrosis. Pathological changes in the kidney. After 42 hours of obstruction, there is dilatation of the collecting system and blunting of the capillaries. After 7 days to 12 days, there is a even dilatation and edema of parenchyma. After 3 to 4 weeks, the cortex and medullary tissue become thinned out. In the blue staining, we can see the collagen deposition in the interstitium space. Here we can see the glomerular sclerosis in chronic obstruction. Histological examination of obstructed renal tissue has a primitive form of renal tissue, and the factors that regulate developmental process are likely target of obstructive effect. Obstructive kidney is smaller than the normal, and biopsy showed the altered differentiation and growth. Obstructive kidney may have impaired or accelerated growth, and obstructive kidney is not atrophic, but it is hypoplastic. And reduced renal mass may cause hypertension and reduced filtration function. Loss of tubular mass affect electrolyte, acid base, and water balance. Differentiation is the process of cell attaining specific function. Obstruction affect gross structural disruption. Transforming growth factor, beta plasminogen, and hepatocyte growth factor are the mediators of differentiation, and it is sensitive that may disrupt the normal sequence. In fetal dysplasia, it is seen in obstruction before 50% of gestation. After this period, only hydronephrotic changes are seen. One of the histological findings are the fibromuscular collar, also called primitive ducts. Persistent expression of alpha smooth muscle actin can also be seen in partial obstruction without dysplasia, and it is regulated by the transforming growth factor beta 1. Profibrotic signal pathway are stimulated and deposition of extracellular matrix occur. Disruption of the interstitium and normal architecture of the kidney. Earliest histological changes are inflammatory cell infiltration into the interstitium. Macrophage infiltration occur in 4 hours. Further infiltration is caused by the cytokine production. Transforming growth factor is the critical mediator of obstruction-induced renal injury. Renal transforming growth factor beta 1 and receptor expression increases in obstruction. TGF beta 1 is a major regulator of renal fibrosis via stimulation of epithelial mesenchymal transition. SMAT2 and SMAT3, which appears to mediate transforming growth factor beta 1 profibrotic properties. SMAT7 is inhibitory and protect against renal fibrosis. Morphogenic protein 7 stimulate SMAT1, 5, and 8 activation and inhibit TGF beta. BMP7 pathway is activated after correction of renal obstruction. And BMP7 during renal recovery promotes the resolution of fibrosis and the restoration of the normal renal architecture. TNF alpha is produced by the renal tubular cells and causes extracellular matrix accumulation and upregulation of cytokines. TNF alpha is also a cytotoxic cytokine and induces renal cell apoptosis. Genetic deletion of TNF alpha receptor and inhibition of TNF alpha pharmacologically can cause reduction in fibrosis and apoptosis. Interleukin 18 is a pro-inflammatory cytokine and early marker of renal tubular damage. Urinary interleukin 18 level are predictive of acute tubular injury before creatinine level rises. Interleukin 18 expression is increased in response to obstruction and directly stimulate the EMT renal tubular cells, inflammatory cell infiltration, and fibrotic injury. Angiotensin 2 is a potent vasoconstrictor. Angiotensin 2 leads to altered hemodynamic and renal fibrosis. It upregulates the TGF beta 1 and TNF alpha expression and ACE inhibition. Inhibition of angiotensin 2 receptor have been shown to decrease the TGF beta 1 expression, and it represents the principal therapeutic approach to slowing renal disease. Angiotensin receptor are two types, type 1 and type 2. AT1 receptor more abundant and biologically significant than the type 2 receptors. Type 2 predominate in fetal life, but receptor decreases in first 3 to 14 days of life. Angiotensin 2 receptor have a vasodilating effect and have a significant role in cellular proliferation and apoptosis. Increased collagen by upregulation collagen gene expression. Collagen synthesis is regulated by the cytokines, including the TGF beta and RAS. Reduced fibrosis may be seen with angiotensinogen activity is downregulated and upregulation of the TGF beta receptor 1 and type 2, and TGF beta receptor 2. Activated fibroblasts acquire mesenchymal markers and migrate into the interstitium space. Blockade of EMT reduces the fibrosis after obstructive injury. Transformation of tubular epithelial cells are regulated by the TGF beta 1. Signaling by transforming growth factor beta 1 is mediated by SMAT, which are profibrotic and inhibitory. Hypoxia induces the hypoxia inducible factor 1 and 2, which increases EMT, known to induce fibrosis. Genetic models that do not express hypoxia inducible factor 1 alpha develop less fibrosis and inflammatory infiltration. Increased nitric oxide generation reduces the degree of interstitial fibrosis, and decreased nitric oxide synthase produces a greater degree of fibrosis. Hemodynamic changes in the unilateral obstruction. It is a triphasic pattern of renal blood flow, and ureteral obstruction changes during the unilateral obstruction. An increase in renal blood flow mediated by the release of vasodilators such as prostaglandin E2 and nitric oxide in the first phase, which lasts for 1 to 2 hours. Then in the second phase, which lasts for 3 to 4 hours, there is ureteral pressure remains elevated, but the renal blood flow begins to decline. In the final phase, ureteral pressure and renal blood flow progressively declines, resulting in the gradual loss of renal function. Here we can see the ureteral pressure and renal blood flow in the different phases. In the first phase, both are increased. In the second phase, ureteral pressure is increased, but the renal blood flow is decreased. Then in the third phase, both are decreased. Uh, Hemodynamic changes in the bilateral obstruction. Initially, in the bilateral obstruction, the renal blood flow increases for about 90%, 90 minutes, then decreases. Ureteral pressure remains elevated for at least 24 hours in bilateral obstruction. Prolonged elevation in intratubular pressure contribute to decrease in GFR. During bilateral obstruction, there is vasodilation, which is followed by the vasoconstriction. Increase in efferent arterial resistance result in increased pressure in glomerular capillaries and intratubular pressure despite a decrease in renal blood flow. Here we can see the both unilateral and bilateral obstruction, which I have explained. Atrial natriuretic peptide appears to have a role in bilateral obstruction. It is responsible for the different hemodynamic responses. Intravascular volume increases in bilateral obstruction. ANP increases afferent arterial dilatation and efferent arterial vasoconstriction, leading to an increase in glomerular capillary pressure and intratubular pressure. A post-obstructive diuresis accompanies relief of bilateral ureteral obstruction, but it is not typically observed with unilateral obstruction, secondary to the presence of functional contralateral kidney that can maintain fluid balance. Urinary concentrating ability. It is dependent on the permeability of the tubules and mediated by the aquaporin and water challenge. Aquaporin 2 is expressed in collecting tubules and collecting duct, and it is vasopressin regulated. After 24 hours of bilateral ureteral obstruction, there is reduction in aquaporin 2 expression in the kidney. It has been demonstrated that aquaporin 2 expression remained 50% of normal level 7 days after relief of obstruction. Aquaporin 1 remained downregulated, causing polyuria and impaired concentration. Decrease in aquaporin 2 levels are observed in obstructive kidney. Decrease in aquaporin 2 levels are observed in non-obstructive kidney, 75% of normal. Neonatal complete or partial obstruction similarly induces a reduction in the expression and distribution of aquaporins. So, decrease in sodium transport is observed after release of obstruction, and this salt wasting also contribute to the concentrating defect observed in obstruction. The natriuresis after relief of bilateral obstruction is typically greater than the unilateral obstruction. Defective hydrogen ion secretion in distal tubule and collecting duct, decrease in bicarbonate reabsorption, and in the proximal tubule there is glutamic uptake and ammonia generation are diminished, and the largest component is the titratable acid phosphate, which is also compromised. Compensatory renal growth is influenced by the age, degree, and duration of the obstruction. Increase in renal volume is due to cellular hypertrophy rather than the hyperplasia. Insulin-like growth factor is mediator of compensatory renal hypertrophy. Insulin-like growth factor 1 is growth factor that has a critical role in renal development, growth, and function. Complete reversal of renal damage is rarely achieved. Glomerular number remains low 1 month after release of obstruction. Glomerular function improves with normalization of GFR 1 month after release of obstruction. GFR decreases by 80% 1 year after relief of obstruction due to glomerular sclerosis. Post-obstructive diuresis is usually physiologic. Sodium, urine, and free water are eliminated. Downregulation of sodium transport channel and aquaporin channels, and poor responsiveness of the collecting duct to vasopressin, altered regulation of the ANP, and post-obstructive diuresis is uncommon in children. Urine output is more than 200 ml per hour or greater. Primarily occurs after relief of bilateral obstruction. Rarely occur in the presence of normal contralateral kidney, and it has been reported in neonates with unilateral obstruction, but it is uncommon. Patient with bilateral ureteral obstruction or an obstructive solitary kidney should be monitored for the development of post-obstructive diuresis. Patient with normal renal function, normal electrolytes, and no evidence of fluid overload and normal mental status should have vital signs and urine output monitoring regularly. They should be given oral fluids. Urine osmolality should be checked. Electrolytes should be monitored every 12 hours or more often. The patient can become hypovolemic because of excess water loss or electrolyte. Abnormalities may develop as a result of salt and potassium fasting. The urine is usually isostheneuric initially. Intravenous fluid replacements with 0.5% saline administration. Cyclooxygenase 2 activity increases in the post-obstructive phase and contributes to polyuria. After administration of selective COX-2 inhibitor, urine output was reduced, but sodium excretion and GFR remain unchanged 24 after release of bilateral obstruction. There is also evidence that sildenafil citrate can induce accumulation of aquaporin 2 channel in collecting duct independent of vasopressin. Renal recovery, according to Wagon et al. Canine model, uh, obstruction in after 7 days there is a 100% recovery, and in obstruction in 14 days there is 70% recovery. After 4 weeks there is 30% recovery, and after 6 weeks there is 0% recovery. Thank you. Sir, in both. Sir.
So you should try this. Stop there. Thank you. So this was more of a theoretical kind, but because it is important from the point of view of examination, theory paper, and soon you are going to sit for the theory exam. So we thought that, yes, why not have this? Because both pathophysiology of urinary tract obstruction and post-obstructive diuresis are important questions which can come in theory. So very important to remember a few things, that this is not a very uncommon thing. In practice, you will come across a lot of patients of urinary tract obstruction and problems related with urinary tract obstruction, particularly bilateral and post-op diuresis. Because post-op diuresis, though physiological for the first 48 hours, it could be pathological after 48 hours if not properly managed. So again, that is again very important from clinical point of view also, how to manage post-op diuresis, and definitely how to manage the obstruction, which may cause obstructive uropathy, nephropathy. So this is a medical emergency. Many times the patient will present with uropathy, nephropathy, acute kidney injury, sepsis, right? So around 10 to 20% patients in some studies, 5 to 10% of patients may have acute kidney injury due to obstructive uropathy. So whenever such a patient comes, you must definitely take a proper history. The commonest causes of there are three important sites where the obstruction can happen. One is the intrarenal ureteric obstruction and the intravesical obstruction. So the commonest cause would be intravesical obstruction, where the cause could be most commonly a prostate enlargement or malignancy of the prostate or urethral stricture, sometimes even phimosis, etc., may cause obstruction and lead to obstructive uropathy, right? So, and the second is ureteral obstruction, where the other causes like uh, even bilateral stones, ureteric stones, urolithiasis, then retroperitoneal fibrosis, uh, tumors which are obstructing the ureters, even CA prostate or other tumors, pelvic tumors, and injury to the ureters of post-surgery, post-hysterectomy, post-retroperitoneal surgery. So all these are important causes for ureteric obstruction. So once, while you take the history, take a proper history of each and everything, the low urinary tract symptoms. Usually the patient with prostate enlargement, say prostate will represent with frequency, urgency, hematuria, etc., and straining, definitely voiding symptoms, etc., before they go into retention. So then the history of surgery, history of any other tumor in the past, history of radiation, chemotherapy given for any tumors, etc. So a very proper history is important. Then the patient may present with other complications, like patient may present with hematuria, may present with urosepsis, with patient may present with a chronic kidney disease uh, due to obstructive uropathy. So the symptoms would be relevant to those complications. So after taking proper history, again, a very important is physical examination, depending upon the site of obstruction. If it is an intravesical obstruction, you may have a retention bladder may be full, there may suprapubic fullness, etc. There may be flank pain, there may be flank fullness due to enlarged kidneys. So it's important, and there may be any mass or lump felt. Sometimes even chronic constipation, fecal impaction can cause obstructive uropathy. That is also again very important. So all this is very important. You do a proper abdominal examination, a rectal examination, genital examination, and then you do investigations. Investigations, again, urine routine is important. Do send it for culture because urosepsis is a common complication. And do a urine protein creatinine ratio also, which is again important. Serum electrolytes, acid base uh, investigation, and blood gas analysis. Then do an imaging study. The commonest would be an ultrasound of the abdomen to find out what is the pathology. And then followed by, if the creatinine is not very high, you can do a CT or MRI. If very high, then you have to avoid them. In MRI, usually you can do in the initial phase when it's a borderline, but now newer generation gadolinium and other agents may prevent this nephrogenic fibrosis, systemic fibrosis, which is common with the first generation gadolinium. So again, as you said about serum creatinine would usually rise when the 50% of kidney is damaged. So it's not a very uh, um, good indicator or biomarker for decreased GFR. Serum cystatin level is available, but another thing which is in the experimental research and which may come in clinically is cyclophilin level of cyclophilin, which uh, again doesn't depend upon the muscle mass and also will rise much earlier than the serum creatinine or cystatin level. So once you have diagnosed all these cases, then you have to manage these cases. So most of these would require some kind of treatment in the form of if the patient comes with urosepsis, electrolyte imbalance, etc. You stabilize the patient. Um, Patient may come with hemodynamic imbalance, etc., volume overload, etc. So you have to first of all stabilize the patient, and then the treatment is the urinary diversion. So urinary diversion is a very important step to do, and then you have to try to prevent all other complications and treat symptomatically and treat the complications like urosepsis, electrolyte imbalance, hemodynamic imbalance, acid-base balance, etc. And as you said, the post-obstructive diuresis again is very important. Many patients, like after putting the catheter, you may have even hematuria because in chronic retention, they may produce hematuria. So you have to manage the patients of hematuria. And if there is post-obstructive diuresis, it's very important how to manage that. So usually 30 to 50% of the fluid is given. It's not the total fluid which is lost. So not you don't actually give the whatever the diuresis is. And how does the diuresis actually affect the kidneys? That is again very important. And what is the pathophysiology of urinary tract obstruction? What happens in the first few hours? There is a compensatory mechanism where there's increased renal circulation, which compensates. But later again, the rise in intratubular pressure, etc., results in ultimately interstitial fibrosis, damage to the kidney, and other things and then the inflammatory process that sets in also causes kidney damage. I think this was in brief about the urinary tract obstruction and the pathophysiology and diuresis. If any of you has any question or a comment to make, Nachiket, you want to make any comment? Uh, Otherwise, if those who have joined us, if they want to make any comment or they have any query, so we can hear you. Okay, so that's the only message chat, I think. We can leave. We can go to the MCQs. Yes.
That's why that you should know about the glomerular response to the product. That is the beginning. It's not the product is the glomerular response. What happens in the 1 hour, this will start. It will take 1 hour to 3 hours, and then the whole structure is very important. The true process is very important.
Right.
So that one was the five response to the glomerular. You maintain a single blood flow. And you need a single something. And then what changes in the first treatment
Yeah. Yeah, because of that's what they're very important to understand these few points, like the basics, right? Obstruction causes a rise in pressure proximally, which results in rise in intratubular pressure. And this is compensated by increase in the blood flow in the first few hours. Later, this blood flow decreases and then causes glomerular damage and etc. And then interstitial fibrosis and inflammatory process which sets in. So the MCQs, we will go into the MCQs. Congenital obstruction differs from acquired obstruction in that it causes renal atrophy, induces interstitial fibrosis, alters renal homeostasis, affects tubular function, affects glomerular development. So it is congenital obstruction, so it should affect the glomerular development, right? Okay. So we'll change glomerular development, whereas acquired obstruction can produce all other changes indicated. Because, yes, yeah. Because it occurs during development and congenital obstruction can produce an altered developmental pattern. Renal dysplasia associated with obstruction is characterized by renal atrophy, glomerular cyst, fibromuscular collars, heterotopic bone formation, excess production of afferent arterial renin. Fibromuscular collars. So you have all read this or you know this. But you should so you should remember because these are more of theoretical and unless you read them, you would not know it. So yes, fibromuscular collars, renal dysplasia is characterized by these. Uh, One of the histological hallmarks of dysplasia is fibromuscular collars, so-called primitive ducts, reflecting abnormal differentiation of the peritubular mesenchyme. Renal growth impairment is common with dysplasia. However, this is not atrophy but growth failure. After relief of a unilateral obstructing lesion, decreasing relative uptake on radionuclide imaging is most likely due to glomerular hyperfiltration, asymmetrical renal growth, established renal tubular fibrosis, and neural imbalance. Unilateral obstructing lesion, decreasing relative uptake on radionuclide renal imaging most likely to asymmetrical renal growth or established renal tubular fibrosis. Is asymmetrical renal growth? Yeah, it's B. When renal function appears to decline after relief of obstruction, it is often due to different growth and functional development rates of the two kidneys. When the affected kidney cannot increase its absolute function as rapidly as the other intact kidney. And this produces a progressive differential functional uptake on nuclear imaging that gives the impression of functional loss that is relative and not absolute. In the obstructed kidney, EGF has been shown to reduce renal apoptosis, reduce glomerular sclerosis, accelerate interstitial fibrosis, improve the collecting duct function, and reduce renin recruitment in the afferent arteriole. Huh? Huh? So EGF has been shown. अरे तुम तो बताओ. C, accelerate interstitial fibrosis. Okay. This was answer? Yeah. Administration of A. Answer is A. Reduce renal apoptosis. Administration of EGF to the congenitally obstructed kidneys can reduce renal apoptosis and reduce the effects of growth impairment. The other effects have not been reported. So that was it. Epithelial to mesenchymal transformation in developing kidney is a one-way process. The basis for glomerular sclerosis, integral to glomerular development, seen only in the setting of obstruction, reflected in the presence of alpha smooth muscle actin. So all these you have taken very theoretical questions. You should have put some clinical aspects, right? So E, answer is E, reflected in the presence of alpha smooth muscle actin. Epithelial to mesenchymal transformations are an important part of renal development, but have not been shown to be part of normal glomerular development. It is the presumed basis for the presence of alpha smooth muscle actin in the obstructed kidneys. It is bidirectional. The regulation of extracellular matrix in the kidney depends on the normal expression of EGF, depends entirely on collagen synthesis, is not related to angiotensin expression, depends on balance synthesis and degradation, is independent of transforming growth factor B beta activity. A, D, depends on balance synthesis. So it depends on balance synthesis and degradation. So extracellular membrane regulation is due to collagen synthesis rates as well as to the rate of ECM breakdown. The latter is determined by the balanced activities of the tissue inhibitors of metalloproteinases and matrix metalloproteinases. These are regulated in part by TGF-beta and the renin-angiotensin system. The principal effects of congenital renal obstruction are glomerulosclerosis, interstitial fibrosis, atrophy, hypoplasia, increased epithelial mesenchymal transformation, altered growth regulation, renal differentiation and functional integration, glomerulosclerosis, renin down regulation, and tubular hypertrophy. A, or it should be C, growth regulation, because it has something with the growth. So something with the development. I think that it should be C, I think. Let's see who is correct. Okay, C. The key patterns defining congenital renal obstruction are altered growth regulation, renal differentiation, and functional integration. Although interstitial fibrosis, tubular hypertrophy, and increased epithelial mesenchymal transformation are components of these changes. In the fetal kidney, angiotensin activity is tightly regulated by EGF, acts predominantly through AT1 receptor, affects epithelial mesenchymal transformation, is important regulation of renal growth, is unaffected by renal obstruction. Hmm? B, D, D is an important regulator of renal growth. In the developing kidneys, angiotensin is an important growth regulator as well as mediator of fibrosis and is altered significantly by obstruction. Fetal angiotensin acts predominantly through AT2 receptor until late in gestation when AT1 receptor begins to exert a great role. So I think these are questions for basic scientists and not clinicians, maybe. Inflammatory change in the congenitally obstructed kidney is similar to those seen in postnatally obstructed kidneys, is mediated by the renin-angiotensin system, is minimally in the absence of overt infection, is the key element in glomerular damage, affects renal interstitial fibrosis. Inflammatory change in congenital obstructed kidney. सब लोगों ने बोल दिया C. So is minimal in the absence of overt infection. In contrast to acquired obstruction, congenital obstruction is not characterized by significant inflammatory infiltrate except when complicated by infections. So that was it. Thank you. So if anybody has any questions. He has no idea. Okay, you can tell him. Just come in. Okay. So the question by Dr. Nachiket was how to produce in animals ureteral obstruction. So one is by tying the two ureters and The simpler method is putting silicon rods in the ureters, which produces per hand. Yeah, B. So which causes partial obstruction and can produce a model, animal model for bilateral aortic obstruction. Yes, thank you. Thank you, everybody. If anybody has any question, otherwise we will just wrap up the session and have a good day.